Hi, welcome to our Pharma Topics channel. Welcome to the B.Pharm 6th semester Pharmacology 3 series. In this, we are going to see about Unit 2, which is related to chemotherapy of non-specific diseases. This has 9 subdivisions, which deals with the general principles of chemotherapy, sulfonamides, cotrimoxazole, penicillin, cephalosporin, chloramphenicol, macrolides, quinolones, fluoroquinolones, tetracyclines, and aminoglycosides. We are going to deal with 21 probable questions with answer explanations in this section. Question number 1 is deals with the general principles of chemotherapy. Basically, they may ask what is chemotherapy. Chemotherapy is the treatment of any disease by synthetic or microbiologically derived substances which kills or inhibits the growth of microbes or fast-growing cells in the body. What are antimicrobial agents? Antimicrobial agents can be synthetic or microbial origin used for suppressing the growth or killing the microbes. What is antibiotic susceptibility testing? It involves two factors. One is minimum bacterial concentration and minimum inhibitory concentration. Minimum bacterial concentration is the minimum concentration of the antimicrobial that kills 99% of the original inoculum. Minimum inhibitory concentration, it inhibits the visible growth of the microbe. What is a bacteriostatic and bactericidal? Bacteriostatic antimicrobials arrest the growth and replication of sensitive microbes and thus limit the spread of infection. Example, sulfonamides, tetracyclines. Bactericidal antimicrobials kill or irreversibly damage the multiplying sensitive bacteria so that the number of viable or living organism count decreases. Example, aminoglycosides. Next, they may ask what are narrow spectrum antimicrobials. Antimicrobials that are active against a single or limited group of pathogens are known as narrow spectrum antimicrobials. For example, isoniazid and rifampicin are active against Mycobacterium tuberculosis. They are narrow spectrum antimicrobials. Broad spectrum antimicrobials, they are active against a wide range of pathogens like gram-positive, gram-negative organisms, spirochetes, chlamydia, and rickettsia. For example, tetracyclines. There is one more concept called concentration dependent killing. This they may ask in short notes. It refers to killing effect of the antimicrobial increase with the increase in the drug concentration. For example, if you increase the concentration, the killing will increase. Example, aminoglycosides and fluoroquinolones. These drugs produce a better action when used as a large single dose as compared to the same daily dose. Daily multiple doses. Time dependent killing. It means killing effect of the drug depends on the length of the time the antimicrobial is exposed. For example, beta-lactam antibiotics and vancomycin. These drugs, when they are administered by multiple daily doses, they have more effect than the large single dose. Post-antibiotic effect. It is a persistent suppression of the bacterial growth after brief exposure of the antimicrobial. In this case, the inhibition of the bacterial growth is seen even when the antimicrobial is stopped. Most of the antimicrobials have a long post-antibiotic effect. That is, the effect of the antimicrobial is there for more than 1.5 hours even after the drug has been stopped. For example, carbapenems, aminoglycosides, chloramphenicol, tetracyclines, quinolones, and rifampicin. Question number 2 is classification of antimicrobials based on the mechanism of action. The first category, drugs inhibiting microbial cell wall synthesis. You remember with the code firmly bind to bacterial cell wall. F is phosphomycin that inhibits the enzyme enol pyruvate transferase. B is beta-lactam antibiotics. And next B is bacitracin. It inhibits dephosphorylation of bactrophenol. C is cycloserine. It inhibits alanine racemase and alanine ligase. And V is vancomycin, which inhibits transglycolase. All these drugs, they inhibit the microbial cell wall synthesis. The next category of drugs, they inhibit the microbial protein synthesis. You remember with the code buy at 30 and sell at 50. That is, Aminoglycosides and tetracyclines bind to 30S ribosomal subunit of the microbes, and whereas streptogramins, erythromycin, that is macrolides, lincosamides, and Linezolid inhibits 50S, they bind to 50S ribosomal subunit and inhibits the protein synthesis in the microbes. Next is drugs affecting the cell microbial cell membrane. They are polypeptide antibiotics such as polymyxin B, colistin, tyrothricin, polyene antibiotics, amphotericin B, nystatin, natamycin, anazoles, ketoconazole, fluconazole, and itraconazole. Then drugs affecting nucleic acids, DNA and RNA. They are DNA gyrase or topoisomerase inhibitors, nalidixic acid, fluoroquinolones, RNA polymerase inhibitors, rifampicin. Drugs which destabilize the DNA helix, metronidazole, nitrofurantoin, and nucleoside or nucleotide analogs which inhibit the viral replication. They are acyclovir, and anti-HIV drugs such as nucleoside reverse transcriptase inhibitors. And the drugs inhibiting microbial folic acid synthesis, that is antimetabolites, are sulfonamides, dapsone, trimethoprim, pyrimethamine, and methotrexate. They inhibit folate synthase and dihydrofolate reductase. So these 5 classifications are the classification of antimicrobials based on their mechanism. Question number 3 is factors influencing selection of an antimicrobial. 2 important factors which decide the selection of the antimicrobial are patient factors and drug factors. Let us see the patient factors. I have given some examples for age. For example, chloramphenicol in newborn may cause grey baby syndrome. Sulfonamides may cause jaundice. Tetracyclines are contraindicated in children because they discolor the bone and teeth, because they form complex with the calcium. Most of the antimicrobials are posing risk to the fetus when used during pregnancy. Penicillins, cephalosporins, and macrolides are safe. You can remember the code PCM. In immunocompromised patients such as HIV and organ transplant cases, bactericidal drugs are preferred. In case of renal function, the drugs contraindicated are cephalothin, cephaloridin, nitrofurantoin, and tetracyclines except doxycycline. Dose reduction is required with aminoglycosides, amphotericin B, vancomycin, penicillins, and rifampicin. Some of the drugs are secreted in bile. For example, cephalosporin, ceftriaxone, tetracycline, rifampicin, erythromycin, nafcillin, ampicillin, and clindamicin, and doxycycline. So these drugs does not require dose reduction in renal failure. They are safe in renal failure. In case of liver function, some of the drugs are contraindicated, such as erythromycin, tetracyclines, pyrazinamide, and pfloxacin. Some drugs require dose reduction in liver failure, such as chloramphenicol, isoniazid, rifampicin, and clindamicin. And there are several examples for genetic factors. Antimicrobials that produce hemolysis in glucose 6-phosphate dehydrogenase deficient patients are primaquine, chloroquine, chloramphenicol, fluoroquinolones, dapsone, and sulfonamides. The drug factors that influence selection of the antimicrobial, it depends upon the spectrum of activity. Some of the drugs are narrow spectrum, some of the drugs are broad spectrum antimicrobials. It depends upon the type of activity also. Bacteriostatic or bactericidal. Bacteriostatic antimicrobials are suitable for patients with normal immune function, whereas bactericidal drugs are preferable in immunocompromised patients and in case of the infections at a less accessible sites such as subacute bacterial endocarditis. And next is sensitivity of the organism. If the drug is more sensitive towards that organism, it could be selected. Then the route of administration. Antibiotics can be intended orally as well as parenterally, whereas many cephalosporins, vancomycin, have to be administered parenterally only. Next question, very important question, is antimicrobial resistance. Antimicrobial resistance or antibiotic tolerance may be natural or acquired. The development of acquired resistance may be with a single step mutation, for example streptomycin, rifampicin, or multi-step mutation for erythromycin, tetracycline, and Chloramphenicol. Drug resistance can be transferred from one microbe to another, either by gene transfer, via conjugation, transduction, or transformation. Conjugation, it's due to physical contact between the bacteria that is responsible for multiple drug resistance, example chloramphenicol, streptomycin. Transduction, it is the transfer of a resistant gene through the bacteriophage, for example penicillin, erythromycin, and chloramphenicol. Rarely, transformation may be a cause for transfer of resistance, example that occurs in the medium, for example penicillin. Then the mechanisms of resistance are decreased affinity for the target. For example, the pneumococci and staphylococci may develop altered penicillin binding proteins. Development of alternate metabolic pathway. Sulfonamide resistant organisms start utilizing preformed folic acid in the place of synthesizing it from para-aminobenzoic acid. They may produce the enzymes that inactivate the drug. For example, beta-lactamases. They inactivate penicillins and cephalosporins. Chloramphenicol acetyl transferase inactivates chloramphenicol, and aminoglycoside inactivating enzymes inactivates aminoglycosides. Sometimes the drugs may have a decreased drug permeability due to loss of specific channels. Aminoglycosides attain much lower concentration in the resistant organisms than the sensitive organisms, and it may also lead to development of efflux pumps that results in efflux of the drug from the resistant organisms, example tetracyclines, erythromycins, and fluoroquinolones. Question number 5 is a very important question, superinfection. It refers to appearance of a new infection as a result of antimicrobial therapy. It is caused by broad spectrum antimicrobials, tetracyclines, chloramphenicol, clindamicin, aminoglycosides, and ampicillin may kill the normal microbial flora of the oropharynx, intestine, respiratory, and genitourinary tracts and lead to development of new infection. The organisms frequently involved in superinfection are Candida albicans, Clostridium difficile, which is more commonly called pseudomembranous colitis. It causes Clostridium difficile associated diarrhea. And the other microbes which are involved in this are Staphylococci, Proteus, and Pseudomonas. The conditions which predispose to superinfection are corticosteroid therapy, malignancies, AIDS, diabetes, and old age. The drugs for treatment of superinfection include fidaxomicin, oral vancomycin, or the first-line drugs for pseudomembranous colitis. Alternative drug is metronidazole. Recently, a monoclonal antibody has been approved, which is called bezlotoxumab for CD/AD. The next question is, what is cross resistance? They may ask in very short notes. Cross resistance is the development of resistance to one antimicrobial that confers resistance to another antimicrobial to which the organism has not been exposed. Actually, the cross resistance is more common between chemically and drugs acting through. That means that if they have similar chemical structures, or if the drugs act through same mechanism. Example, resistance to one sulfonamide causing resistance to all the other sulfonamide drugs. Resistant to one tetracycline causing resistance to all the other tetracyclines is called cross resistance. Then what are the reasons for failure of antimicrobial therapy? It is improper selection of the drug, dose, route, or duration of treatment, non-compliance to therapy, poor host defense. Infecting organisms are present behind the barriers such as subacute bacterial endocarditis, if they are present inside the eyeball, and if the antibacterials are prescribed for viral infections, and presence of dormant or resistance organisms. Question number 8 is the sulfonamides, antifolate drugs, and trimethoprim. The sulfonamides are bacteriostatic. Sulfonamides competitively inhibit the enzyme dihydroteroate synthase, and trimethoprim inhibits dihydrofolate reductase, and thus conversion of folate to tetrahydrofolate is reduced. The sulfonamides are given oral or by IV infusion. Sulfa drugs pass into inflammatory exudates but are inactive in the presence of pus. Cotrimoxazole is a combination of sulfamethoxazole and trimethoprim. It is used for It is given in the ratio of 5:1, that is 5 parts sulfamethoxazole and 1 part trimethoprim. Is used for pneumocystitis, pneumonia, toxoplasmosis and nocardiosis, urinary tract infections, acute exacerbations of chronic bronchitis. Trimethoprim alone is used for prostatitis, urinary and respiratory tract infections. Combined with pyrimethamine, sulfonamides are used to treat drug-resistant malaria and toxoplasmosis. The adverse effects of sulfonamides include GIT upset, rashes. Very rare but serious adverse effects are Stevenson-Johnson syndrome, blood dyscrasias, toxic epidermal necrolysis, photosensitivity, and crystalluria. Trimethoprim folate deficiency with resultant megaloblastic anemia is possible on long-term treatment with cotrimoxazole. Question number 9 is beta-lactam antibiotics, penicillin. The type of penicillins are 3 types. One is beta-lactamase resistant penicillins, methicillin, flucloxacillin, temocillin. Broad spectrum penicillins are ampicillin and amoxicillin. Extended spectrum penicillins are piperacillin and ticarcillin. The penicillins are bactericidal in nature. They interfere with the cell wall synthesis in the dividing bacteria. They bind and inhibit the enzyme that cross-links the peptidation of the newly formed building block to the peptidoglycan cell wall backbone. It is a transpeptidase enzyme. Oral absorption varies. It can be given by intramuscular or intravenous route. It crosses the placenta but does not cross blood-brain barrier unless the meninges are inflamed. The penicillins are excreted in urine, which is blocked by probenecid. Therapeutic uses: benzyl penicillin is used for bacterial meningitis, and flucloxacillin is used for skin, bone, and joint infections. Amoxicillin with clavulanic acid is used for animal bites. Phenoxymethyl penicillin or penicillin B is used for pharyngitis. And benzyl penicillin with aminoglycosides are used for treatment of otitis media, bronchitis, and pneumonia. And piperacillin and ticarcillin are used for infections with Pseudomonas aeruginosa. The adverse effects of penicillins include hypersensitivity reactions, which are rashes, urticaria, angioedema, fever, arthralgia, and anaphylaxis. The beta-lactam antibiotics such as cephalosporin, they may ask a short note. This is the question number 10. These are bactericidal, interfere with the cell wall synthesis. The mechanism is very similar to the penicillins. They bind and inhibit the enzyme that cross-links the peptide chain of the newly formed building block to the peptidoglycan cell wall backbone. Some cephalosporins are given orally, but most of them are given by IM or IV injection. They pass into all body fluids. They are excreted in urine, which is blocked by probenecid. They excreted mostly via kidney, but 40% of ceftriaxone is eliminated in bile. The therapeutic uses: cefotaxime is used for treatment of septicemia. Ceftriaxone, cefotaxime are used for treatment of pneumonia caused by susceptible organisms and meningitis. Then cefadroxil is used for biliary tract infections, urinary tract infections, and sinusitis. Adverse effects are hypersensitivity reactions such as rashes, urticaria, angioedema, arthralgia, anaphylaxis, GIT disturbances, rarely hepatitis, and cholestatic jaundice. Question number 11 is carbapenems. A short note on carbapenems. They are beta-lactam antibiotics. The list of carbapenems are imipenem, meropenem, ertapenem. They are bactericidal. They interfere with the cell wall synthesis. The mechanism is same. They bind and inhibit the enzymes that cross-link the peptide chain of the newly formed building block to the peptidoglycan cell wall backbone. They are given by IV infusion, pass into body fluids including CSF, that is cerebrospinal fluid. The imipenem is inactivated by renal enzymes, so must be given with cilastatin, which inhibits the enzyme renal dehydropeptidase and increases the half-life of imipenem. Therapeutic uses: they are broad spectrum, active against gram-positive, gram-negative, and anaerobic bacteria. They are used to treat severe polymicrobial Hospital-acquired infections, example septicemia, pneumonia, and complicated urinary tract infections. The adverse effects include GI disturbances, rashes, and injection site reactions. Next is a short note on AZTREONAM. It's a beta-lactam antibiotic. It's a monobactam. It's a monocyclic beta-lactam antibiotic. It binds with the penicillin binding proteins and thereby blocking a peptidoglycan cross-linking and inhibits bacterial cell wall synthesis. It's used to treat infections caused by gram-negative rods such as Klebsiella, Pseudomonas, and Serratia. AZTREONAM can be used to treat severe gram-negative infections in patients who are allergic to penicillin or in patients who are renally insufficient and thus cannot tolerate aminoglycosides. Adverse effects: GI upset, skin rash, and elevated liver function test. It's not a cross allergen of penicillin. Question number 13. It is the blockers of peptidoglycan synthesis. They are vancomycin and teicoplanin. They may be asked in short notes. Vancomycin and teicoplanin are glycopeptide antibiotics. They are bacterial cell wall peptidoglycan synthesis inhibitors. They inhibit the synthesis of cell wall. These drugs are slowly bactericidal for dividing microbes, impair the permeability of bacterial cell wall membrane and RNA synthesis. They are given by IV infusion used for treatment of Clostridium difficile infection orally. Therapeutic uses: treatment of infections caused by MRSA, that is methicillin resistant Staph aureus, penicillin resistant enterococci, and Clostridium difficile infection. Adverse effects: reversible ototoxicity, vestibular and cochlear toxicity, hypersensitivity reactions. Rarely nephrotoxicity may occur, and rarely excessive rate of infusion can cause erythematous rash on the face and upper body, that is red neck or red man syndrome. Red man syndrome can be asked in 2 marks. Daptomycin is a new lipopeptide antibacterial with a similar spectrum to vancomycin. It is used in treatment of methicillin resistant Staph aureus. Telavancin is also active against methicillin resistant Staph aureus with a longer duration of action than vancomycin. Question number 14 is tetracyclines. They are bacterial protein synthesis inhibitors. The tetracyclines include tetracycline, doxycycline, and oxytetracycline. They interfere with the bacterial protein synthesis by competing with the tRNA for the A site of the ribosome and reversibly inhibit its binding to mRNA codons in the 30S subunit. Can be given orally, but the absorption is impaired by milk and by calcium, magnesium, and iron preparations. Doxycycline is the drug of choice for chlamydial, rickettsia, and brucella infections. It's effective in most chest infections, include mycoplasma and Haemophilus influenza. Tetracyclines are useful in acne, sinusitis, prostatitis, Lyme disease, and in treatment of malaria. Democlocycline is used in inappropriate secretion of antidiuretic hormone, that is SIADH, and causing hyponatremia. Adverse effects include staining of teeth, GIT disturbances, anorexia, flushing, tinnitus, hepatotoxicity, pancreatitis, and hypersensitivity reactions. Because they form chelation with calcium in the bone and the teeth, they cause a discoloration of the bone and the teeth. Tetracyclines should not be given to children or pregnant or breastfeeding women. Next is aminoglycosides. They are bacterial protein synthesis inhibitors. The aminoglycosides include gentamicin, streptomycin, amikacin, tobramycin, and neomycin. They cause misleading of the mRNA message due to abnormal codon-anticodon recognition with the production of abnormal proteins by binding to 50S ribosomal subunit of the microbes. They can be given intramuscularly or by slow intravenous injection or infusion. They can be given intrathecally also. They get excreted through the renal route. It is useful in infections with staphylococci, along with the beta-lactam antibiotics, streptococci, enterococci, septicemia, meningitis, endocarditis, and pneumonia. The adverse effects include dose-related ototoxicity and nephrotoxicity, GIT disturbances, rash, blood disorders. Aminoglycosides, when they are co-administered with loop diuretics, it increases the risk of ototoxicity. Aminoglycosides, when they are co-administered with neuromuscular junction blockers, they increase the risk of muscular blockade. Question number 16 is bacterial protein synthesis inhibitors, macrolides. The macrolides include erythromycin, clarithromycin, and azithromycin. Macrolides inhibit the bacterial protein synthesis by an effect on the ribosomal translocation. They bind to 50S subunit of the bacterial ribosome. They can be given orally or by IV infusion. The erythromycin half-life is 1.5 hours. And these drugs are distributed widely but does not enter the brain or CSF. The macrolides are useful for treatment of pneumococcal and streptococcal infections in patients who are allergic to penicillin. These drugs are used for chlamydial mycoplasma infections. It's used for infections of the skin and respiratory tract, for syphilis, diphtheria, prostatitis, whooping cough, and enteritis. Azithromycin is more effective against Haemophilus influenzae and may be more active against Legionella. Clarithromycin is effective against Haemophilus influenzae and Mycobacterium avium intracellular and may be useful in leprosy and also used for treatment of peptic ulcer disease caused by Helicobacter pylori. Macrolides, the adverse effects include GIT disturbances, allergic reactions, cholestatic jaundice. Intravenous infusions can cause phlebitis. Tetracyclines are CYP3A4 inhibitors. When they are co-administered with statins, they increase the risk of myopathy or rhabdomyolysis. Question number 17, it's a short note on chloramphenicol. It's a bacterial protein synthesis inhibitor which inhibits transpeptidation in bacteria by binding to 50S ribosomal subunit. It can be given orally or by IV injection or infusion, enters CSF and CNS. It's inactivated in the liver and also available as eye drops. Chloramphenicol is used mainly for life-threatening infections of Haemophilus influenza, for meningitis resistant to penicillin, and for typhoid infections. Chloramphenicol is used topically for bacterial eye infections. It can cause dose-related bone marrow depression. Gray baby syndrome can occur in neonates who lack the relevant inactivating enzymes, causing group of symptoms such as causing circulatory collapse, flaccidity, and vomiting. Aplastic anemia can occur in few genetically predisposed individuals. Question number 18 is bacterial protein synthesis inhibitor, Clindamicin. It is amino sugar antibiotic. It binds to 50S ribosome, prevents translocation of nascent peptide from the acceptor site to the peptide site. It can be given orally or IM injection. It's used for treatment of infections caused by streptococci, staphylococci, penicillin-resistant staphylococcus, and many anaerobes, such as except Clostridium difficile. It is used for lung abscess, for bone, skin, and joint and soft tissue infections. It can cause Clostridium difficile associated diarrhea, CDAD, pseudomembranous colitis. It is a higher incidence when compared to other antibiotics. Clindamicin, when it is co-administered with neuromuscular junction blockers, it can potentiate the action of neuromuscular blockades. Question number 19, short note on Linezolid. It's a bacterial protein synthesis inhibitor, binds to 23S ribosomal RNA of the 50S ribosomal subunit. It is used for treatment of infections caused by vancomycin resistant Enterococcus faecium, methicillin sensitive and methicillin resistant Staph aureus, and penicillin sensitive pneumococci. The adverse effects include thrombocytopenia in persons with renal insufficiency or with prolonged therapy. Linezolid can cause serotonin syndrome when it is co-administered with selective serotonin reuptake inhibitors. The next question, question number 20, is a short note on quinolones and fluoroquinolones. These drugs are bacterial topoisomerase inhibitors. They include ciprofloxacin, levofloxacin, ofloxacin, norfloxacin, moxifloxacin, and nalidixic acid. They inhibit the enzyme DNA kyrase topoisomerase 2. This is the enzyme that produces the supercoil in the chromosome that is essential for transcription and replication in the microbial cells. Fluoroquinolones are well absorbed orally. They accumulate in several tissues and also concentrated in the phagocytes. Only ofloxacin crosses the blood-brain barrier. Elimination of ciprofloxacin and norfloxacin is partly by CYP enzymes and partly by renal excretion. These drugs are active against gram-positive organisms, particularly gram-negative bacteria. They are used for infections of the urinary tract, GAT, bone and joint infections, respiratory tract infections, but it's not useful against respiratory infections caused by pneumococci. It is used for gonorrhea and septicemia caused by sensitive organisms. The adverse effects include tendon damage, aortic dissection, gait disturbances, infections with Clostridium difficile, GAT upset, headache, dizziness and rashes. It should be avoided in older patients and patients with renal damage and patients who have undergone transplantation. Fluoroquinolones absorption is affected by the antacids. Ciprofloxacin, when it is co-administered with theophylline, it increases the risk of theophylline toxicity in asthmatics. Fluoroquinolones, when they are administered with steroids, they increase the risk of tendon injury. And the last section is miscellaneous antibacterials. These can be asked in very short notes. Quinupristin, dalfopristin. It binds to 50S ribosomal subunit. The quinupristin inhibits amino acid transfer RNA synthesis and addition of amino acids, whereas dalfopristin inhibits peptidyl transferase. It's used for MRSA infections, infections of skin and soft tissues, hospital-acquired pneumonia, and vancomycin resistant Enterococcus faecium. The adverse effects include infusion site reactions. Mupirocin is an antibacterial that competes with the isoleucine for binding to bacterial isoleucyl tRNA synthetase. It is used for treatment of impetigo caused by staphylococci and streptococci. It's used for treatment of infected traumatic skin lesions. And the very important antibacterial is polymyxin colistimethate, which is advanced antibiotic. It disrupts the bacterial outer cell membrane, and it is selective bactericidal for gram-negative bacilli. It is used for Pseudomonas and coliform organisms. It's a very short information of all the antibacterials and which are used for non-specific diseases. I hope it will be useful for your exam preparation. Thank you for listening. Happy learning. Kindly share this to more of your friends. Kindly go through all the series which are present in the BPharm 6th semester and score well in your exams. Thank you.